I would now like to turn the call over to your speaker today, Robert Anthony with the Office of eHealth Standards and Services. Robert, please go ahead.
Thank you. Thank you to everybody who has showed up today to hear about this, and thank you to PAHCOM for hosting this. My name is Robert Anthony. I'm with the Centers for Medicare and Medicaid Services, and I work specifically on the Medicare and Medicaid EHR Incentive Programs. We're going to cover today sort of an introduction and overview of what the EHR Incentive Programs are. I do want to clarify for those of you who may be a little further along with the EHR Incentive Programs that we did just recently release a Stage 2 Notice of Proposed Rulemaking. That is not what we're going to cover today. We're going to cover basics of the program, eligibility, how you participate, where you can go for resources, and some important things you should know to be able to participate. We will be doing some information later on down the line, and of course there is information on our website as well, which I'll direct everybody to. So the first thing that I want to do is I want to talk a little bit about eligibility and what the program is structured like. Eligibility, we often get the question of how it was decided who was eligible. Actually, eligibility was defined in the HITECH Act, which was part of the Recovery Act legislation that was passed. So the actual categories for eligible professionals and hospitals that can participate were defined there. It was also defined that eligible professionals who furnish substantially all of their professional services within an inpatient or emergency room of a hospital would not be able to participate. And the theory being that hospitals would receive incentives for the services that those EPs were providing already, and we wanted to incentivize EPs who were not hospital-based to participate. So within the regulation, you'll see that the definition for hospital-based EPs is 90% or more of your covered professional services are in either an inpatient or emergency room. That's POS 21 or 23 of a hospital. So if one of your EPs falls into that category, they are not eligible to participate. They may, if they are one of the EPs who really hover around that 90% mark, it is possible that they might not be able to participate, say, this year, but they might be able to participate next year. So keep checking year after year. The other thing, and I've seen in some of the questions, people are asking, can my neurology practice participate? Can this practice participate? So on and so forth. When it comes to incentives for this program, they are not based on practice. They are based on the individual eligible professional. So your neurology practice can't participate, but the eligible professionals within the neurology practice may be eligible for an incentive. And I'll talk a little bit about what those categories are next here. So when we look at the eligible professionals that can participate on an individual basis, there's a Medicare program and there's a Medicaid version of this program. On the Medicare side, it is primarily physicians. It's doctors of optometry, doctors of podiatric medicine. I saw that somebody asked whether a chiropractor could participate, and yes, they are an eligible professional. Doctors of medicine and osteopathy, doctors of dental medicine or surgery. Those in the middle there in the overlap, that medicine and osteopathy, dental medicine and surgery, are also eligible to participate in Medicaid. But in addition, there are some non-physician EPs on the Medicaid side, nurse practitioners, certified nurse midwives, physician assistants, when they are working at a federally qualified health center or a rural health center that is also led by a physician assistant. There are a number of people who have been asking questions, and I'll deal a lot of questions on the side when we get to the end, but I see a frequent question is whether the presentation deck will be downloadable. It isn't right now, but we will reach out to everybody through email to follow up with how you can get a hold of that slide deck and maybe some follow-up information as well. On the hospital side, it is primarily subsection D hospitals, critical access hospitals on the Medicare side. On the Medicaid side, there is some overlap. There's actually a large amount of overlap. Almost everybody is going to fit right into that middle section. But in addition, there are children's hospitals, some acute care hospitals in U.S. territories, and cancer hospitals that would be available. So in addition, on the Medicaid side, to being one of the 5 types of eligible professionals, you also have to meet patient volume requirements to be able to participate. This is on the Medicaid side. You have to have 30% or more of your patient volume from Medicaid, unless you are a pediatrician, in which case it is 20% or more. Or if you practice predominantly in a federally qualified health center or a rural health center, you can qualify if you have 30% or more of your patient volume from needy individuals. Obviously, you have to be licensed and credentialed in those categories that we talked about before: doctor of medicine, certified nurse, midwife, so on and so forth. You can't have any OIG exclusions against you. We do compare you against what we kind of grimly call our master death file, but it's essentially practitioners who had participated in the past but are no longer living. So we have to make sure that the person receiving an incentive is on the living list. And then, of course, you can't be hospital-based, as we discussed before. On the hospital side, it is acute care hospitals with 10% or more Medicaid patient volume. That's generally going to be your short-term stay cancer and critical access hospitals and children's hospitals. On the Medicare side, you have to be a physician. Somebody just asked the question, what about doctors of ophthalmology? So if you fit into the category of an MD, a DO, doctor of dental medicine, surgery, podiatrist, chiropractor, optometrist, if you're a physician, you're going to fit into that category. You have to have Part B Medicare allowed charges. That's what we base your incentive payment on. Your incentive payment on the Medicare side is 75% of your Medicare Part B allowed charges up to a certain maximum each year. If you don't bill Medicare for anything, then we're not going to be able to pay you any incentive because we won't have anything to base it on. Again, you can't be hospital-based. And you have to be enrolled in PAHCOS. That's our provider enrollment chain and ownership system. Many of you probably know that pretty well. If you deal with Medicare, it's how we associate payment for different physicians and other healthcare professionals. So you want to go through and you want to not only check on your PAHCOS status, but make sure that you're connected to some of these other areas. I encourage everybody to register early for this program. I would encourage you to register right now. Registering now does not mean that you are committed to participating in the program, but registering now will let you know if you have any PAHCOS issues or if there are any other system issues, because we do checks at that time to see about your OIG status and your PAHCOS issues and everything else. So sometimes those can take some time to resolve, and if you register now, you can find out about them right away. Medicare hospitals are going to be the subsection D hospitals in the United States, or DC, and of course the critical access hospitals. I'm going to focus from here on out primarily on the Medicare, primarily on the eligible professional side, because I think that's what a lot of people are looking at. So how much are the incentives here? Medicare incentive payments, as I said, are based on the fee-for-service, the Part B allowable charges. The maximum incentive that you can receive is $44,000 over 5 years. 2012 is the last year that you can begin participating in Medicare and receive the maximum payment amount. 2014 is the last year you could begin participating on the Medicare side and receive any payments. You do receive the payments in consecutive years, so if you begin in 2012, then you have to participate in 13, 14, 15, and 16 to continue receiving those payments up to the maximum. The absolute last payment year on Medicare is 2016. There is an extra bonus amount that is available for an EP who practices predominantly in a health professional shortage area. That's a federally identified HPSA area, and that's a 10% bonus, which means that you would receive your maximum incentive of $44,000 plus an extra $4,400. And then the other thing to keep in mind is, although hospitals can participate in both the Medicare and Medicaid programs, they can receive payments from each of the programs. If you're an eligible professional, you have to choose one of these programs, either Medicare or Medicaid. On the Medicaid side, the incentives are higher. It is $63,750 over 6 years, and that's 6 non-continuous years. It's just 6 years anywhere within those payment years. So in other words, you could come into Medicaid in your first year and get a payment this year and then not come back and do anything with the program until 2016, and that's perfectly fine. You could still get your maximum incentive. So it's structured a little differently than Medicare is. The incentives are the same regardless of when you start although you do have to begin by 2016 to receive incentive payments. The first year payment for Medicaid is $21,250. So you can already see that the payments are higher, the structure is a little bit looser. If it is possible for you to qualify under Medicaid and you can meet those patient volume requirements, we do encourage people to do it because you can maximize your incentive payment. The other quirk, if you want to call it that, on the Medicaid side is that the first year of Medicaid, you can receive a payment for adopting, implementing, or upgrading a certified EHR. When you first participate in Medicare, you have to immediately begin with what we call meaningful use, and that is meeting certain objectives to show that you are using your certified EHR in a meaningful way that will affect patient care. There are thresholds for these different measures that you're going to have to report to us, and that's how you qualify for a payment. On the Medicaid side, your first year, you can adopt, implement, or upgrade a certified EHR, and we'll explain that on our next slide. The incentive payments on Medicaid are available through 2021. So Medicare ends in 2016 with payments. Medicaid ends in 2021. There isn't an extra bonus on the Medicaid side for health professional shortage areas. And of course, again, if you participate, you have to choose one program or the other, Medicare or Medicaid. Somebody did ask about switching from Medicare to Medicaid. It can be done. It can be done once in the course of the program. So adopting, implementing, or upgrade, you have to use in this program to qualify for a payment a certified EHR technology. It's basically an EHR that has been certified specifically to work with this program and have the right standards and capabilities to allow you to achieve the objectives of meaningful use that you'll have to achieve. So in Medicaid, in your first year, you can actually get paid for putting that certified EHR into place. So you can get paid for adopting, which is basically acquiring the EHR or acquiring access to the EHR. You don't necessarily have to personally have paid for it. You don't even actually have to, in some areas, have the certified EHR in your practice. Sometimes you just have to have a commitment, a financial commitment, something that shows a contract, for example, that shows that you've purchased the EHR that will be implemented. Of course, you can also get paid for one that you have purchased and have implemented, and you can also get paid for upgrading. So if you have a version of EHR technology that in its previous version was not certified for use with this program, but is certified in a later version, you could upgrade to that later version and get a payment for it. I'm going to talk now about meaningful use, and these are the thresholds and objectives that you have to hit in order to qualify for a payment immediately under Medicare, and then after you do your first year of adopt, implement, upgrade under Medicaid, then you'll move into doing these meaningful use requirements as well. So this is sort of what we envisioned meaningful use being. This is how we envisioned the EHR incentive programs. We talked about this in our Stage 1 final rule that we published in 2010. It's a three-stage process. Right now we are in Stage 1. That's where this red circle is, and the emphasis of these objectives is really on capturing data about patients and sharing that data with other providers. It's really about getting technology in place and getting providers to start to use it. We have published a Stage 2 Notice of Proposed Rulemaking that we will finalize later in this summer, and that is going to focus more on advanced clinical processes like robust health information exchange, thinking more about patient care. And eventually in Stage 3, which we will publish a couple years from now, we'll be looking at objectives that are really targeted towards improving patient outcomes, because that ultimately is the goal of meaningful use. That is the goal of the EHR incentive programs. It is to improve the quality of health care for patients and improve overall outcomes for everybody, whether that is reducing costs through reduction of health care tests or whether it's improving chronic care of patients. So everybody starts their first year of meaningful use by doing a 90-day period, a 90-day EHR reporting period. So if you're in Medicare, the first year you participate, you'll do 90 days of a reporting period of meeting these objectives and then attesting to having met them. If you're in Medicaid, your first year of participation will be AIU, that Adopt, Implement, Upgrade, and then your second year will be 90 days of meaningful use. After you do your 90 days of meaningful use, then the next year and every year thereafter, you're always going to do a full year of meaningful use. You'll always do stage 1 as your first 2 years of meaningful use. Once you have done your reporting period, once you have finished it, you actually will report through us through attestation. And attestation is a very fancy word for you log on to our website and you will provide us some data from your EHR that shows that you have met the particular objectives we've set up. And we're going to look at some screenshots a little bit later on. But essentially what you'll have to do is you have these objectives, meaningful use objectives that you have to hit. And there are objectives like e-prescribing, where more than 40% of the prescriptions that the EP writes during the reporting period have to be electronically prescribed. Things like recording vital signs, where height, weight, blood pressure are recorded within the EHR for patients. There are thresholds to a lot of these examples, like the 40% for e-prescribing. There are also exclusions for some of those, and I'll talk about that in a second. The other component of this is that you have to report data on clinical quality measures. Everybody has clinical quality measures that we ask them to report on, and these are similar for those of you who participate in some other areas like the physician quality reporting system. They're similar to those type of measures. There aren't thresholds for those clinical quality measures. You're just required to report them, and we'll talk a little bit more about that. You're going to find as we go through some of these that the reporting may either be a yes-no or it could be a numerator-denominator information. So an example of a yes-no is we have an objective where you have to use drug-drug and drug allergy interaction alerts, and the measurement and what you will attest to is that you have enabled the use of drug-drug and drug allergy interaction checks for the duration of the EHR period, and you would literally in the web attestation say yes or no to that. Others of them are like the e-prescribing that I described, in which you will have to put in a numerator and a denominator, and we will use those to calculate whether you exceeded the 40% threshold. There are certain objectives that are going to require you to have a percentage of your patients, minimum percentage of your patients with records in certified EHR technology. We do recognize that in the beginning you're making a little bit of a transition from a paper-based system to an electronic-based system, and we do know that there's going to be some lag for some patients, but there are a couple of measures that require you to base your numerators and denominators on all of the patient records, not just patient records that exist in the EHR. So you're going to have a minimum in order to participate in meaningful use and receive an incentive payment. You're going to have a minimum of 80% of those patients that you see during the reporting period have records in the certified EHR. So I'm not going to go through each of the objectives. We're actually going to do that on another call that we do with PAHCOM and everybody, and we'll go a little bit more in depth into individual objectives and things that you might need to know and things that you'll have to go into. I'm doing more of an overview of the structure right now, and right now I want to let you know these are the stage 1 objectives and measures that you're going to be reporting on to us. And we have some information about this on our website, and I'll show you a link in a second. But stage 1 is where everybody is going to begin. It's the first step of the escalator. And if you're an eligible professional or you have eligible professionals in your office, each of them are going to have to report on 15 core meaningful use objectives. And when we say core, we basically mean everybody has to do those objectives unless they qualify for an exclusion. And again, we'll come to that. And then there is a menu set of 10 objectives, out of which you have to pick 5 to report on. So a total of 20 meaningful use objectives that you have to meet. And one of those meaningful use objectives is reporting on the clinical quality measures. If you're an eligible professional or you have eligible professionals, you're going to have to report data on 3 core or alternate core clinical quality measures. These are 3 core measures, and if you are not able to report on one or more of those because you don't have a population they apply to, you'll report on one or more from the alternate core. Then there's a menu set of clinical quality measures that consists of 38 clinical quality measures, and you would select 3 that are applicable to your workflow. It is entirely possible that you will not have any clinical quality measures in that list if you are a specialist that apply to your workflow, in which case you can pick any 3 and report on those. You'll end up reporting zeros. That is perfectly okay to report a 0 on these because there is not a threshold to meet with the clinical quality measures. Hospitals have the exact same structure, many of the exact same objectives. They have 14 core objectives, and again, 5 out of 10, and they have a set of 15 clinical quality measures to talk about. I'm not going to go through the objectives here. We will go through them at another time, but if you want to look at what they are, you can find detailed information on all of them through our meaningful use specification sheets. You can find those on our website. The address is here, and you can go to the meaningful use tab. If you scroll to the bottom, there's a section for eligible professionals. There's an individual sheet for each of these 25 objectives. It lists what the objective is. It lists the measure that you have to hit, the threshold that you have to hit. It shows you what we require in the numerator and what we'd require in the denominator. It defines certain terms. So if you don't understand what a clinical summary is, it defines what elements are in a clinical summary. And then it gives some detailed information that will really help you in meeting the measure. So I encourage everybody to take a look at those, and that'll give you much more detailed information. Again, we're going to cover some of this in another webinar. As I said, some of these meaningful use objectives aren't applicable to everybody's scope of practice, and that's why we have provided for exclusions. Certain measures, like e-prescribing, have an exclusion provided that if you meet or your EP meets that exclusion, the EP can indicate that they meet it and not have to report on it and still receive an incentive payment. So for example, e-prescribing, where you have to do 40% or more of your prescriptions electronically, the exclusion is if the EP writes fewer than 100 prescriptions during the reporting period, they can be excluded from that objective. They don't have to meet it. They don't have to report on it. You'll indicate that in attestation. The exclusions don't count against the menu measures that you do. So in other words, we encourage you to select menu measures that you can report on, but it is entirely possible that you're going to have menu measures that you will have menu measures that don't apply to anything that you do, and that you will qualify for exclusions for those, and in which case it is fine to indicate exclusions within those menu measures. But there are specific things, for example, for I mentioned e-prescribing, chiropractors who don't e-prescribe. There's an objective to submit immunization data to an immunization registry. Well, if you're a dentist, the chances are pretty good that you're not doing any immunizations. There is an exclusion if that is not a normal course of practice for you. So again, those meaningful use specification sheets will give you a complete rundown of that. If your EPs work in multiple settings, and this is more and more common these days, where they work for multiple practices, they contract with multiple practices, or they work for practices that have multiple offices. We do have a threshold that at least half, 50% of the EP's total patient encounters have to be at locations where there's certified EHR technology available in order to participate. So basically half of your patient encounters have to be on certified EHR in order for you to take part and receive a payment. And then you would basically base all of your meaningful use measures on just those locations with the certified EHR. We talked a little bit about clinical quality measures and how you have to submit that information. It has traditionally, it was in 2011, based on attestation, which is how you put your meaningful use data in. You visit our website, you log on. I'm going to show you how to do that. You put in your numerator, denominator information, and you submit it to us. In 2012, we are introducing the possibility of EPs participating in an electronic reporting pilot. Somebody asked a question here about whether you could submit meaningful use information electronically. You can't submit meaningful use information electronically at this time, but we are piloting a program for submitting your clinical quality measure data through this pilot program. If you're interested in that, I urge you to take a look at our website, go to our clinical quality measures section. It'll give you a lot more detail about how you participate in that pilot. Quick recap of the difference between the program. Obviously, CMS is administering the Medicare version of the program. It is voluntary for states to implement the Medicaid EHR incentive programs, but to date, 43 of the states are participating, and we do anticipate that the remaining states are going to come on board in 2012. So we think that all of the states are going to be participating. Check with your state Medicaid agency for more information about their participation. Medicare does have payment adjustments. If you are not a meaningful user, if you do not show us that you have meaningfully used technology by meeting these objectives, we're going to start assessing payment adjustments beginning in 2015. There aren't any Medicaid payment adjustments. However, if you are an EP who is eligible for both programs, you're going to have to show meaningful use in order to avoid the Medicare side. You could show meaningful use for Medicaid, that's fine. We share data with the states, but you're going to have to show meaningful use. Again, in Medicare, you're going to do your meaningful use, your 90 days in that first year, whereas in Medicaid, you're going to do your adopt, implement, upgrade. The incentives are higher in Medicaid, so if you can meet the patient volume, I highly urge you to do that. There is a provision that allows states to add some additional requirements for meaningful use through the Medicaid program, and I mention this because legally they can do it, but to date, no state has requested the permission to do that from CMS, and we do have to grant permission for it. So at this point, it's not an issue. Keep in mind that the last year that you can begin the program and receive a payment for Medicare is in 2014. The last year that you can register at all is in 2016, whereas with Medicare you have a little bit of a longer stretch. The last year to begin and register is in 2016. And we already discussed a little bit about who can participate. I want to show you some screenshots of what you can expect when you go to the attestation and registering module. Everybody, regardless of whether you're Medicare or Medicaid, is going to start in the same place. You're going to go to our website, the www.cms.gov/EHR Incentives Program. It's going to take you to our home page, and on the left side there is a list of tabs that you can click onto. If you click either register or attest, you're going to find within that page a link to our registration and attestation module. It really doesn't matter whether you click register or attest. It's going to take you to the same place, but there is different information on those pages. When you click through, you're going to go through and register if you're participating in Medicaid, it'll ask you to indicate that. And then when you complete your registration through there, what we're going to do is we're going to hand off your information to the state, and then they'll complete the rest of the verification to allow you to participate with your state Medicaid agency. We have something here that says the states pay no later than 5 months after you register, but I will tell you that we've got 39 states that are making payments at this point in time, so that's happening a lot sooner than the 5 months. When you come to the registration and attestation system, you're going to log on. You're going to log on using your NPES and NPI accounts. That's the National Plan and Provider Enumeration System accounts. You're probably using a similar web user account already to access other CMS systems, so you use the same thing here. And when you go into the system, you're going to end up at a home page like this that's going to have a few buttons on it. The buttons there mimic the tabs at the top. They basically take you to either the registration, attestation, or status page. The status page just lets you see where you are on things. If you have not registered yet for the program, you won't even be able to select these other tabs. You'll have to select registration, and that will take you into an area in the beginning where it will show you your EP, their tax ID number, the National Provider Identifier number. If you haven't done anything, you won't see the incentive type or the registration status because you won't have indicated whether you want to participate in Medicare or Medicaid. You'll just see this button that says register, and you'll click that, and then you'll go forward. Some folks have asked about an INA account. If you use the Identity and Access Management System to allow people to access other CMS systems on your EP's behalf, you can do that for this as well. We're managing through the exact same system, the INA system, and you use your INA password to log in there. You can also, at this point in time, you cannot do an attestation for every EP at the same time, but you can submit batch registration through INA, and there's some detailed information on that on our website. We are proposing a batch reporting for attestation in our Stage 2 NPRM, but that's not active at this point in time. Once you push that register button, it's going to take you forward. You can see this screen. It'll ask you to select which program you want to take part in, Medicare or Medicaid. It'll ask you to select your eligible professional type, of medicine or osteopathy or chiropractor or whatever it happened to be. It'll ask you if you have a certified EHR. At this point in time, when you register for the program, you don't have to have a certified EHR. We're just interested in whether people who are registering already have selected one or not. If you do, it would be great to get your certification number. That's the certification number of the product. There's a link here that will tell you how you get that certification number. If you don't have it, you just say no, you leave that area blank, and you hit save and continue. An important thing to keep in mind is that anywhere in the registration or attestation modules, when you hit save and continue, any information that you have put into the system up to that point is going to save in that system. For registration, that's probably not as big of a deal. It's a pretty quick process. You go through, you click through, you verify business address, things like that. For attestation, which asks for a lot more data, it might be more useful for you. You may be able to come, fill out some information, hit the save and continue, come back to that later. So just be aware of that as you go through. Once you do submit your registration, you're going to find out whether you've been successful with the submission. If it is rejected, it'll say rejected submission, and it will tell you why under those bullet points. Usually it's because there's a PAHCOM problem. So again, that's why I urge everybody to register now. You can find out if you've got this PAHCOM issue and take care of it. Sometimes those things do take time, as I'm sure everybody knows. You'll get a registration ID number once you get a successful submission, and we do have an ability here for you to print the receipt. I highly suggest people print receipts, although we all know that nothing ever goes wrong with computers. It would be fantastic to have this on hand if it did, because when you call our information center, that's what they're going to ask for. At this point, if you are a Medicaid person, you're going to complete the rest of your attestation with your state. It's going to take over your registration and do everything else. If you are a Medicare participant, you're going to come back to the same module when you finish your meaningful use and you've done your objectives and you have your data. You'll come back to the exact same module, and that's where you'll do your attestation. You will log in the exact same way with your NPES or INA, and then your attestation tab, you'll be able to click on that tab and you'll be able to start that process. So here's a physician who has not done any attestation yet. You can see a name, a tax identifier, their NPI. You'll see that status and program year and payment year are blank right now. You can only press that attest button, and once you press that attest button, it's going to start walking you through each and every one of those objectives. And I want to show you what those look like because I know it produces a little bit of anxiety in folks. So here is an example of one of the core measures. This one is for implementing drug-drug and drug allergy interaction checks. We talked about that a little bit earlier. And as I said, it gives you the objective, tells you the measure, and then it asks you, did you enable that functionality for the entire EHR reporting period, yes or no? So you indicate yes or no in that, and then you hit save and continue, and it's going to move you on to the next measure. So here's one on keeping an up-to-date problem list of current and active diagnosis. It gives you the measure. It defines exactly what the numerator is, which is the number of patients in the denominator who have at least one entry in their problem list, a denominator, which is the number of unique patients seen by the EP during the EHR reporting period, and then it provides you some space to enter the values of your numerator and denominator. You're going to get those numerators and denominators primarily from your EHR. Your EHR is going to have a report that it will be able to spit out. You do not have to base these numbers solely on that report, not for your meaningful use objectives. You will for your CQMs, and I'll explain that when we get to that section. But you won't have to do it specifically on these. You may have to add in some information for those patients who hadn't yet transitioned to the electronic. So all of your unique patients might not be in your EHR at this point. You might have to do a little addition. You can click here on the link for the Meaningful Use Measure Specification page. That's going to take you back to the specification sheets that we talked about earlier, and it'll take you to the exact specification sheet for this core measure. So for each measure, you'll have that in case you have any questions. We talked about exclusions. We talked specifically about this exclusion for e-prescribing. This is how you'll end up indicating it. Whenever there's an exclusion, it's going to pop up with that particular measure, and it's going to say, is this any EP who writes fewer than 100 prescriptions during the reporting period is excluded from the requirement? Does that exclusion apply to you? If you click yes, it's going to take you to the next measure, and that measure won't be counted against you. If you say no, then it's going to ask you for the numerator-denominator information that we showed earlier. Menu measures, you select 5 out of 10 of the menu measures. This is how you're going to select them. It'll show you the objective in the measure, and you'll put a check mark in the box next to the 5 that you want to actually attest to. And then once you select those 5, it's going to walk you through a screen that is similar to this. This is actually an older screenshot, but it's the same type of thing. This one is for generating a list of patients by specific condition. It's a yes-no answer, and it'll show you yes, no, and a save and continue. You can do clinical quality measure reporting through the website, or as I said, you can do it e-reporting through the pilot program. This is what we were talking about earlier. You can go to the web page, and it will give you some information about that. It'll ask you during attestation, do you plan on e-reporting, or do you plan on reporting through the website? If you're planning on e-reporting, then you would indicate yes, and you won't do any of this clinical quality measure section here. You'll submit through the e-reporting pilot. If you say no, it's going to actually walk you through the individual clinical quality measures. Here is one of the core clinical quality measures that all EPs have to report on. This one is for hypertension. It is important to note when you go through this that for the attestation portion of clinical quality measures, denominator comes before numerator, whereas for the meaningful use objectives, the numerator comes before the denominator. There's actually a reason why it's done. It's because of the way that the measures are e-specified, but I just want everybody to be aware of it because it can get kind of confusing and generate some errors for you. Some of the clinical quality measures do have multiple populations that you report on. This is sometimes a little confusing to people, but this is the point at which I usually like to tell folks that the thing about clinical quality measures from your perspective is that it's going to be really easy to report on. It's not like meaningful use objectives where you might have to add in some information from some other areas and you might have to figure out about doing these things. The way that you report clinical quality measures is that you generate a clinical quality measure report from your certified EHR, and your EHR is certified to do this, so every EHR will do this. You'll press a button, it'll generate a report. It'll have the denominator, numerator, sometimes some exclusion number information in there. And you will literally transcribe those numbers from that report into this system. You have to do that in order to report on clinical quality measures. So there isn't anything that you're going to have to do on your end except press a button and transcribe numbers for the clinical quality measures. Some of them have, like I said, this exclusion information over here on the right. Exclusions for clinical quality measures, for those of you who don't know, are a little bit different than the type of exclusions we were talking about earlier. In this case, it's actually people who are excluded from being part of this measure. The number of people out of that denominator. So, in this case, this adult weight screening applies to patients who are aged 18 years or older. Presumably the exclusions here would be patients who don't fall in that range, so they'd be 17 years or younger. You have to select 3 out of 38 additional clinical quality measures. If you're an EP, you're going to select those the exact same way that you select menu measures that you want to report on for the meaningful use objectives. You put a check mark in the box, and then it's going to walk you through each of those individual clinical quality measures that you've chosen. So you're going to submit the information on your attestation. It'll walk you through some screens, some legalese and things to do. And you will find out immediately whether you have met meaningful use or whether you haven't. Here's an example of not meeting it. It'll say rejected attestation. It'll tell you why. In this case, there were mistakes in both the core and in the menu measures. you didn't meet the thresholds for whatever reason. If you didn't meet those thresholds, you can go back and look at the information you entered, and if you discovered that you entered it by mistake, you can correct information, and you'll see a report like this in the summary status with the objective to measure. In the entered column, it'll be actually the values that you put in. You can take a look at those, and sometimes you'll see that, oh, I transposed a couple of numbers, or I did something wrong on one of these, and you can go into the edit section and change the values of that and resubmit, and it does not count against you. So this is a lot of information on the overview, and there's obviously a lot more information about incorporating this into your clinical workflow. I'm going to cover a couple of questions, but I also wanted to point you to where you can find some really in-depth resources. I really encourage everybody to go to our website. I have said this on several other webinars, and it always bears repeating. If you were going to look at only one meaningful use website, please let it be ours. It's not because I get a penny for every time that you hit the link. It's because we are the last and most authoritative word on meaningful use, because we are the agency that administers the program. It's also because you're going to find a lot of really useful information that you're not going to find in other places. I know that PAHCOM sent out a link to everybody a little earlier about our introduction to the EHR Incentive Programs. It's going to cover some of the same ground that we talked about here, but even a little bit more in depth. It is written specifically for office managers and practice managers who are starting from square one on this. Maybe this is a project that you had suddenly dumped into your lap and you really don't know where to begin with it. This is a great intro and overview to the program. You're also going to find frequently asked questions there. The frequently asked questions range from everything from how soon until I get paid after I attest, it's usually about 8 weeks, to really detailed questions about, can I send information in this way in order to meet a particular meaningful use objective? Those are great things to have access to. You can have access to the actual regulation if you want. Our spec sheets are there so that you can look at those as well. We have a meaningful use attestation calculator, which actually allows you to put in your numerator and denominator information before you go to attestation and see if you would be able to meet all of the thresholds and qualify for an incentive payment based on what you're going to enter. There are registration and attestation user guides that give you screenshots of the registration and attestation process. They walk you through step-by-step of what you have to do, not just for this, but also for the identity and access management system to grant somebody access for this. So take a look at those guides. They're also going to give you some tips about things that you should be prepared to have for particular screens. And then finally, you can go to our website and sign up for our listserv. I recommend that everybody does this. We not only tell you when we have new information available on our website, when we have new educational resources, when there are webinars that we are running that you can sign up for and you can learn about, when there are new frequently asked questions that may give you some helpful information. It's the latest and greatest of what's happening with the program. And we use it, too, to remind you of when deadlines are fast approaching. When's the last day you can start your 90-day reporting period this year, so on and so forth. If you have questions about certified EHR technology, there is some information on our website. You can also go to the Office of the National Coordinator's website. They do oversee the certification process, and they do maintain a list of every product that has been certified for use with this program. Please visit them. They're going to give you some information about certified EHR as well. We do have some numbers. Again, this deck, we're going to email you some instructions for how to get a hold of it, so these numbers will be available to you. There's an EHR Information Center help desk that is specifically set up to answer questions about this program, registration and attestation. I have a couple of people who are saying, I've tried to register, I've tried to attest, I'm having some issues. Please call our information center. They're going to set up a remedy ticket for you. They're going to walk you through the process. They're going to make sure you get the help you need. If you have some issues with your NPES access, maybe you don't know your username anymore, maybe you don't know your password anymore, maybe you know it all and it's just not letting you in, please call the NPES help desk. They're going to be able to walk you through it. If you go through the registration process and you discover that you do have some PAHCOS problems, you can call our EHR Information Center. or you can call the PAHCOS help desk directly. That's who they're going to hook you up with to solve some of those problems, and they'll be able to walk you through some solutions. And then finally, if you have some questions with that identity and authentication system, not identity and access, that INA system to grant access for that, there's a help desk phone number there as well. As I said, there's registration and user guides. We do have some past webinars on our website with transcripts available that you could take a look at, and there are specification sheets for both meaningful use and for the clinical quality measures. So I'm going to run through some of the many, many questions that we have here over on the side, and hopefully I'll be able to make it through at least some of these. I'm going to start somewhere randomly, and I'll just sort of flip through them randomly. Somebody did ask about receiving a letter from Medicare stating that one of your physicians didn't submit 10 e-prescribing during the reporting period. That's not actually for the EHR incentive programs. That is because of the e-prescribing incentive programs. There is a penalty adjustment for that. The cut is not permanent if you begin e-prescribing, and in fact, if you participate in the EHR incentive programs, which has an e-prescribing component, then you won't be hit with that penalty. But please go to our website and look up the e-prescribing incentive program. It's also sometimes referred to as MIPA, M-I-P-A-A, and that will lead you to some more information about things. There was some question, and this comes up fairly frequently, about an ambulatory surgery center. If you're a surgeon who practices in an ASC that doesn't have an EHR system, can you claim reimbursement for him, and then next year if he gets an EMR system, can he claim himself for reimbursement but take him off of your reimbursement? So I'm going to talk first about the reimbursement issue, and then I'm going to talk secondly about the ambulatory surgery center issue. You as an ambulatory surgery center cannot receive the incentive payment directly. You can receive an incentive payment. Any practice can receive an incentive payment if the eligible professional who has completed meaningful use and is eligible for the payment indicates that his check should go to you. There are a lot of EPs who reassign their payments to their particular practice, but there are EPs that are in multiple practices, and they're going to have to make a decision about how that payment gets assigned. The particular practice or ambulatory surgery center is not able to do that for them without them granting permission to do it. We get a lot of questions about ambulatory surgery centers in particular, and whether physicians who practice within an ambulatory surgery center are required to participate in the program, or whether they'd be subject to payment adjustments. And the answer to the question is really that it depends. We don't segregate physicians by where they practice outside of inpatient and emergency departments. So essentially, when we talk about meaningful use for EPs, we are talking about all outpatient ambulatory encounters. So anything that is not POS 21 or POS 23 would potentially make the EP eligible. And as long as they are not a hospital-based physician, so they don't do 90% or more of their services in 21 or 23, then they could be eligible for the program. So we're a practice that has 3 physicians and a nurse practitioner. Is the nurse practitioner eligible? The nurse practitioner could be eligible under Medicaid if they can meet the patient volume requirement. The nurse practitioner would not be eligible under Medicare. Somebody asked about being eligible for both Medicare and Medicaid, that although you are eligible for both, you can only participate in one, and that's correct. If you are a hospital, you can receive payments from both. But if you are an eligible professional, you have to elect to participate in one program or the other. I'm flipping sort of randomly here. There is a question about what is the allowable charge definition for which we base the Medicare incentive payments on. It is Part B covered professional services, so it is things that hit your the fee for physician claim area. We have a little bit more of a further breakdown if you visit our website and you go into an FAQ and you look at and you search by either Part B or hospital-based. it'll turn up an FAQ that'll give you a much larger definition, but it basically boils down to Part B, covered professional services. It is what we reimburse you, not what the physician's fee schedule is. If an eligible professional attests with Medicaid for Adopt, Implement, Upgrade payment in 2012, when is the earliest that he or she could attest for meaningful use? So your first year would be AIU, and then your second year of participation would be meaningful use. Now you can do that meaningful use the next year, in which case you would do your 90 days in 2013. But you're not required to, because Medicaid can be non-continuous. Somebody asked about their physician being registered. They think they're registered, but they're not sure. Sign in under the NPES web user and ID and check. That'll give you what the registration system is. And if they're not registered, register them right away so you can see whether there are any kind of issues. Somebody asked an excellent question. When you do reporting for your attestation data, does it apply only to your Medicare or Medicaid patients, or does it apply to all of the patients in your practice? It applies to all of the patients in your practice. We talked a little bit about this in the Stage 1 regulation that we released, and essentially it comes down to the feedback that we got from a lot of physicians was that it would be pretty burdensome to ask them to figure out, while a physician was treating a patient, which one was Medicare, which one was Medicaid, how things were billed. So it is based on all of those. Somebody asked about seeing patients in a nursing home, a question that comes up quite a bit. They handwrite notes in their charts. Is it illegal or wrong to enter an EHR record in addition to those written notes? Does it have to be verbatim? Well, first of all, let me say that notes and note-taking are really not covered by any of the meaningful use objectives that we do. There was a proposal to do that for Stage 2. We decided not to include it, but it's not there for Stage 1. So how notes are handled is completely the purview of the EP. I will say that some people see patients in a nursing home, and many nursing homes don't have a certified EHR, and they ask whether they can enter that information later when they get back to their practice, and that does have certified EHR. And the answer is that you can do that, but there may be some issues for you with one particular objective, and that objective is computerized provider order entry, which has to be done for medication orders before any action can be taken on that medication order. And the reason is because CPOE can generate medication alerts, these drug allergy interaction checks, which can lead to some better patient care. It can head off some issues that may be there. So it may not be possible for you to enter orders using CPOE by entering orders after you've seen a patient in a nursing home. Somebody else asked a really good question about whether the EP is the only person who can enter information into the certified EHR. I think somebody else also asked whether a medical assistant could enter that information. And the answer is that the vast majority of the information that is being required, we don't specify who enters that information. In fact, if you look at the measures, it says specifically, for something like vital signs, it says that those vital signs have been recorded in the EHR for that patient. So it doesn't specify who does it, and that's really a workflow decision for practices, with the exception of one objective, and that objective is computerized provider order entry, which has to be entered by somebody who is a licensed healthcare professional who can take clinical action based on any alert that may pop up because of that order. So that's really the only restriction that we have. Very often people have existing practice management systems that do appointment billing appointments. They have billing software that has some other information. I know of practices that are actually doing interfaces between their certified EHR and their practice management system in order to allow some of the demographic information to be fed directly from the system rather than re-entering it. And that's perfectly okay. A question about whether nursing home physicians were excluded. we talked a little bit about whether they could enter that information, but the truth is that nursing home physicians are not excluded, and that those particular areas that they do visits in are going to count towards their total denominator. Now, if they can do 50% of their patient encounters in an area with certified EHR technology outside of those nursing homes, then they'll be able to participate, receive an incentive, and avoid any payment adjustments. If by 2015 we do not participate in meaningful use, will we be penalized by both Medicare and Medicaid? There are no payment adjustments on the Medicaid side. There are payment adjustments that begin in 2015 for Medicare EPs who elect not to participate. We have detailed some of that information in our proposed rule for Stage 2, and people who want a little bit more information about that timeline, I would urge you to take a look at that. Again, Stage 2 isn't finalized. This is just a proposal. We are seeking comment, and we encourage people to take a look at this. If I didn't cover your question, if I didn't answer everything that you're looking for, we are going to have another webinar a little later that's going to go into more in-depth about meaningful use. I encourage you to take a look at our EHR Information Center, phone them, and submit questions to them. But your first stop, really, if you can go to our website, which again, www.cms.gov/EHR Incentive Programs. Make sure you put the S on the end of it. You're going to find a wealth of materials that is going to walk you through things. And we are at the end of our hour. I'd like to thank everybody for taking the time to listen. I'd like to thank PAHCOM again for hosting this. I'd really like to thank all of the office and practice managers out there. I know that a lot of you are the folks that implementation is going to fall on, and we're really looking for ways that we can get information to you and serve you. So hopefully this has been useful, and thanks a lot.